G'day, mate. How did I do there, Benoy? I'm working on me Aussie accent. That was pretty appalling, probably, wasn't it? Hi, everyone. Morning, afternoon, evening, wherever you are in the world, listening to the Aussie UK dynamic duo. I'm not quite an Aussie just yet, but I am working on my lingo. That's been my PD actually recently, Benoy. My colleagues have been very kind in teaching me the Aussie lingo.
Yeah, and how do you find the whole settling down? Because it's been a few months there. How do you find like the whole culture side of things, not the clinical side, but the whole vibes? And is it a bit different?
Oh, it's very different to London. It's too relaxed for its own good, but I love it. It's very relaxed, very chilled out, slow pace. Definitely enjoying it, but I do get called out if my lingo is not correct. So if we get time, I might share a little bit with you that I've been learning.
Yeah.
How are you keeping, Benoy?
Yeah, good. So sort of, as I said, we're just recovering from a bit of a cold and other things. But the summer is coming. The spring has started here. So there's a lot of, usually it's quite a busy time with a lot of events as well. So going to Holland next week. So it'll be good to covering a little bit of tendon rehab stuff. We also had the BHS conference, which I couldn't attend because of overlap. So again, for young guys, is look out for conferences, evening events. There's a lot of free evening events, especially in London. I think you gain a lot by networking.
100%.
As a junior, when I was 5 and 6, I used to go for most free events because I couldn't really afford paid events at the time. So I was going a lot of hospitals in London do a lot of evening events with consultants. So it's a great place. How about where you work? Do you get a lot of MDT events there with the hospitals and consultants?
Yeah, we do. I've been very fortunate to observe a surgery a few weeks ago with top hip surgeon here. I'm shadowing another one in a clinic in a 2 weeks' time. We do have a free event actually in North Perth in a couple of weeks in a sports medicine centre. So
is it open for other physios or just
really good? Yeah, no, it's open to everyone. It's open to all physios. It's open to everyone. I mean, I did say this in our last episode, Benoy, and I'm sorry to call you out on this again, but I am still waiting for my invite to Holland.
Yeah, but I think it's a short flight though, isn't it? From but you never know. So yeah, we could. Yeah, I think maybe next year we should plan a big masterclass in Perth. So get it out there, get all the. That could be definitely, because I had people asking as well, so we can definitely plan that. Oh, when you come down, so that's definitely on the cards.
I'm getting a few messages, I think I said last time, from some Europeans. So I think I will be coming back to London next year. So I think you and I need to arrange something, Benoy.
Bali, somewhere halfway, we could fly to Bali.
We could do Bali or Thailand. Yeah, that's an option, isn't it?
Yeah. We can
Let us know what you think, guys.
Yeah. Where do you want us to do our face-to-face even, because I think there's a provider here who does something called surf camps, or where they do a bit of half-a-day teaching and then they go for surfing and things. I think that's not a bad concept, isn't it? So...
Yeah, I mean, we can't. Can you surf, Benoy? I can't surf, but we could give it a go.
Yeah, definitely. No harm. It's never too late. You can't. They say you can't teach your old dog new tricks, but I beg to differ. I can pick up a few things.
You're not an old dog, Benoy. You're not an old dog.
Good. All right then. So what
serious
are we
stuff? On to the serious stuff. On to the nerdy stuff. So we're talking today about why patients fail conservative care with FAI syndrome. That's been our topic for our first set of episodes. Benoy, I know this is something that you get a lot of second opinions. You're obviously very established in London, so you're getting a lot of these type of cases. I'm very new to Perth. I am seeing some at the moment. My longest one is a lady coexisting FAI hip dysplasia for 2 years. Conservative management ×2, had injections, wasn't working. Thankfully, touch wood, we're doing very, very well. So we're seeing quite a lot of this, and that's what we're going over today. Benoy, before we jumped on camera, you said you've got a bit of a checkpoint. You've got a bit of a checklist that when someone comes to you, and in the context of, we think it's FAI, and they've had it for a year, 2 years, 3 years, and they're not improving, what's your checklist that you're going through to try and ask why has this happened to inform your decision-making?
Yeah, I think that's important to have a structure, because that's what I think pretty much entire my caseload with my APP clinic with hips is people who have done physio or conservative care before. So it's important to have, it can be quite overwhelming when you have so much information. So I go through this sort of key points where I find will answer around 80 to 90% of the cases. The first thing is it really FA syndrome? We know the FA syndromes, those symptoms and signs are not very specific. It can overlap with other pathologies. So that's why we did an episode called the FA mimickers. So if you're interested, you can look. There are about 6 conditions, 3 common and 3 uncommon, which can have pretty much exactly the same clinical testing, because the all the testing we do doesn't really tell us what type of intra-articular pathology. So there are 2-3 sneaky ones which sit in the back. One is a bit of OA, early OA. So you got somebody like 42 or 38 who's got the impingement picture, but already getting that OA picture, and which is not sometimes seen on an obvious X-ray. So sometimes the OA changes are only seen on an MRI or an ultrasound. So, but they're getting all the symptoms like stiffness, shoes and socks. So that management will be very different from an impingement patient, because that's more like long-term options, expectations. Sometimes they are not bad enough for a replacement. So that's a big one. The second one is hip dysplasia, especially with a young female. They can have overlap. About 30 to 40% of hip dysplasia will also have 𝐾AM morphology. So you get a mixed picture. These are very difficult cases. The mixed picture in young females who are hypermobile. So they have a bit of hypermobility, they have a bit of 𝐾AM, they have hip instability. So this is where I think things can be quite difficult. So there are 2-3 things which we can use here. This is where diagnostic hip injections are extremely useful to determine where the source of pain is. It adductor? Is it GTPS? Is it intra-articular? So this is an MDT decision. And also some sneaky extra-articular pathology, especially the proximal ITB, especially in the runner, can also mimic FA syndrome. So it's going through that checklist of those 3 common. So these are the 3 common. And then obviously we have the uncommon ones like AV and ischiofemoral impingement and things like that. So you go through the checklist, check their typical presentation, do your testing, and make sure that things coexist. Because the thing here is things can coexist. So you can have FA syndrome with proximal ITB. You can have FA syndrome with dysplasia. You can have FA syndrome with early OA. So it's not like mutually exclusive. But that's why we love hips, is because it's never straightforward in that way. But what's the main driver here? So not to fall into one single factor thinking. So that's the first area I would explore too. What would you add there, Callum?
Yeah, completely. And I think that's important to touch on there, Benoy, is that when we're teaching, well, when anyone's teaching, when we're trying to learn, we have to put things into boxes, don't we? So what does FAI look like? Dysplasia, GTPS, ischiofemoral impingement, etc. And it's important to learn in that way for pattern recognition. But in real life, things coexist. Yeah. And what you've got to be, hopefully, we're trying to encourage people to get really good at, is recognizing the patterns that look like the primary drivers. Because, these things don't tend to exist in a nice, neat little box as much as we would love them to. So, no, that's a summary, my summary, I think, of what you've just said there.
Yeah. And that's where I think imaging, working with the second opinion, getting an X-ray looked at. So many times, one of my main jobs in guys is people email me all the time. Every day I get 1 or 2 X-rays saying, can you please have a look on this X-ray to make sure we're not looking. So you need to have a buddy system. Second referral, people get make sure that you're not missing out, because you can't be good at everything, and also you can miss things, especially if you're not seeing them a lot of those. So the first thing is misdiagnosis. It was never possibly a FA syndrome on its own. The second one is failure to modify activity. So the load management is a major issue. So I see people come, obviously when people come to me who've done rehab, I'll always check, can you please show me what the rehab you're doing? Most people will have an app like PhysiTrack or something like that. I can see the exercises. So I look at the exercises. The exercise is perfect, really. There's nothing I can fault on. The exercise has been fantastic. But where patients fail is patients still continue to do with high provocative activities. So they're really pushing into enrage, loading into the gym. They're starting with the 𝐂𝐚𝐬𝐿 on week 1. We were just talking about 𝐂𝐚𝐬𝐿. I have nothing against 𝐂𝐚𝐬𝐿. I've been there, but it's not the great exercise on. It's not the great exercises on week 1. For somebody with an adductor or a FA, and then you and me, we hate the clamps. People on clamps sort of stuff. Alison Grimaldi has done a post on that. So the moments the exercises or the loading is too provocative, or they have not reduced the load in the sports, they're still playing 4 times 5 aside, they're still running uphills, they're still sprinting. So for me, the checklist is, are they provocating the hips either at the gym, either at the sports, or either at work? Those are the 3 areas I look at. What are you doing at the work? What is your chair like? So I think this is where I think you've done, you've gone through in detail where you've gone through activity modification. So people can go back and listen to the activity modification. So I'm not going to spend much time on that. But you don't get anywhere with FA syndrome without load modification and failure to reduce the provocative loads. You pretty much lost the battle.
Yeah, it comes back to, you've said this, Benoy, I think even in the last podcast, we're not dealing with a tendon here that you can, we'll call it someone without metabolic issues, good health, whatever. It's an overloaded mechanical tendon problem. Yes, we can go for it. When you're dealing with the joint, we're talking about the hip joint here. I was saying to you, Benoy, off camera, I'm seeing recently a lot of 𝐂𝐚𝐤𝐤s being given out in the first 6, maybe 8 weeks of I'm just saying hip and groin rehab, whether it's neuropathic drivers, whether it's the adductor muscle, whether it's FAI. And look, I'm all for 𝐂𝐚𝐤𝐤s. They're an awesome exercise. There are other adductor related, hip flexor related exercises. A 𝐂𝐚𝐤𝐤 is very, very aggressive on the adductors, the aponeurotic tissue that insert onto the pubis, the inguinal region. It's very, very high loads. And I don't think there's enough appreciation of that. So keep things really simple, deload it a bit. We can smash 𝐂𝐚𝐤𝐤s later down the line. But something I've seen a bit recently is the exercises have just been a bit too aggressive too soon. That's probably a pattern I've spotted recently.
Yeah. And again, we have to also sometimes, the patients also push you, because these patients are generally very fit people and they also want very high level exercises. But you have to start with the boring stuff first, low level stuff, and then build it up as well. And that goes to the next point, is severity of morphology here. Sometimes it's not the fault of the rehab. Sometimes the patients are doing the right things, but sometimes there's a mismatch here. So you got somebody with a large alpha angle, 85 degrees, a large cam, and very poor internal rotation, like 0 degrees or 5 degrees. And they're doing a high level rotational sports, for example, hockey, tennis, or CrossFit. And we know for those sort of sports, you need at least 15 to 20 degrees of internal rotation. So there's a mismatch here, and something has to give. So you can rehab really well, but every time they go back to that high level rotational sports, the body is not able to cope up because of the biomechanical load, because we know that if you don't have the rotation, then it's going to affect your back mechanics. You're going to have issues with hip extension. The whole kinetic chain gets really problematic here. So these are very difficult patients because the morphology doesn't match what they want to get back to. And they have to make a decision. One option is maybe they reduce the intensity of the sports and go for a lower level, or they might have to take that going for hip arthroscopy, try to modify the morphology. So this can be quite tricky here. What do you think on this quite a tricky point here, isn't it?
Yeah, this is a very difficult subject, and this is where your communication skills will really get tested with this demographic. I know it does with me, because if you think about the sporty population, this is part of who they are. This is their identity. And look, for some people, it's actually how they make their living as well. And I've got, I'm learning a lot of that here in WA, hockey, netball, especially. People make their living from this. So it then becomes a decision of, are we going to reduce that / give that up? And if that's an absolute no-go, then yeah, sometimes we have to bite the bullet and say, okay, we might have to get a surgical opinion here for a possible arthroscopy. So surgery isn't a bad word. Ejection isn't a bad word either. We spoke about it in the last podcast. I haven't got a recipe here, Benoy. I don't have a playbook here on this is the script that you need to follow. Yeah. But sometimes we do have to have these difficult discussions.
Yeah, but also an important point here is also having very clear expectations for the surgery. So they'll say, okay, I'm going for surgery and then I can go to bike sports. But there are two problems here. The first problem, not a problem, a real situation. This is not, I'm telling the reality here is, one is it's a long rehab. Is the squeeze what the, what's the famous line? Is the juice what the squeeze? They say that, isn't it? I picked it from Enda King.
Yeah.
Yeah. So, are you willing to go through all that work for a bit more sporting work? Are you going to spend 1 year of your life going through all that? You need to be mentally prepared for that. Some people will be. Some people are very tough, and they'll say, yes, I'm happy to give that. But they need to know what they're getting into, number one. And number two, even with the best surgeons, it's not a guarantee that he'll get back. There's a possibility that it may not make a big difference high end. But so there's a risk involved there. And I'm not taking any sides here. I'm just playing, giving them the honest feedback here. Is it something you touch as well?
Yeah. You're playing devil's advocate. In this case, and this is where the physio. This is where we are the devil's advocate in this sense, because you're absolutely right. Surgery is invasive. It comes with risk. We won't go into all the risks that could come from it, but sometimes complications happen, whether that's in the surgery, whether it's post-operatively, and no one can predict that. So you're right. It's a case of, listen, is this sport at this level, is incredibly important to you and something you are just, there's no budging, you're not willing to give it up. If they say, no, actually, yeah, I can change this, that, and the other, it's a different conversation. If it's no, that this is who I am, I need to keep doing this, then just, okay, we'll go down the surgical route. You spoke in the last episode, Benoy, about networking. Really sell sort of the surgeon, say you're in very good hands here, but manage the expectation that it's a big surgery. You're going to be in pain afterwards. It's going to be a very slow journey. We could be looking at 6 months. We could be looking at as long as 12 months. If you're up for that, we're up for that. Let's go for it.
Yeah. And also, this is where the prehab comes in. So I try to say, if you do go for the surgery, I'll help you out. I'll support you. We'll get you as strong as possible. Do the prehab, get yourself as strong, as less pain as possible. So it's a teamwork. So, but they need to be mentally interested and motivated for that. So that's where the physio input is hugely important. And that goes to the next point, is what I call a more inadequate generic rehab, where patients fall through. So they come to you, you've done the rehab, and after 2 months, they don't come back. So, and you think, what's happened? Because they lose motivation, because this is where I think good physios have to also be good salesperson for the rehab. You need to give them a vision. So we need to tell them, like we talked on the last episode, the 3 phases here, coming down the hip, which could be anywhere 4 to 6 weeks. What are the benchmarks? So the next phase, how to build up the resilience and the capacity. The third is the sport specific stuff, giving them clear benchmarks. A lot of times some physios struggle with that end stage where they don't transition. They start with the physio stuff and then they rush them too much early return to running. So this is where we have a more targeted, good plan. Otherwise, patients feel that they're not really progressing and they feel like it's bit merged. So people get lost here. So this is where I think the compliance is important. So how do you sort of lock people in for 3 to 6 months? What's your tips and tricks here, Callum, to get them engaged?
Yeah, this is actually interesting, Benoy, because I've had not a surgical case. This is a conservative management case of a masters hockey player that I've got at the moment, a lady in her early 50s, FAI, it's led to arthritis. She's also got proximal ITB coexisting. She's had 2 physios previously. Her biggest complaint, I can't remember the word you just used, but her biggest complaint was that she did not feel stimulated with the rehab. So you got to think.
Yeah. That's quite. I've never heard that. People say that. Because it's not engaging enough. A better word be it's not engaging, isn't it? Yeah.
She
didn't feel like getting anywhere.
She didn't feel stimulated with her rehab at all. Yeah. So we got to keep in mind that these are active athletic people. So even I'm using this as an example, and I am linking it to a preoperative kind of engagement. As physios, I think it's important we've got knowledge of training principles, because for them to buy in, my opinion is they need to feel stimulated. They need to feel mentally engaged, like they're getting something out of going to the gym.
Yes.
So that's one of my biggest sales pitches, based off of this lady who's doing fantastic, because she was essentially told, where you said a minute ago, Benoy, you said inadequate generic rehab. Giving out banded exercises done at home and stretching, it's boring. Active people don't want to be doing exercise at home. So I would divert people back to a previous episode where we spoke about how do you modify your training? How do you modify positions? Because that's all I tapped into. We push the upper body stuff, we push the cross training, and that is a big sales thing for me here, is to be like, look, we're still taking you into the gym, you're still lifting, we're still getting your heart rate up, we're still getting a sweat on. We're just going to modify this,
make some tweaks, modify this. A little bit of tweaks, yeah.
That's all we're doing. If they go, oh, okay, so I can still go to the gym even though I've got surgery in 3 months. Yeah, of course you can. Because we need to push you. We need to get you strong. I need you to feel stimulated in the gym. I need you to get a sweat on.
Yes.
If that's probably my biggest sales pitch to them, because a lot of times people have been told, just stop running, stop gym, stop everything. No. Here's some bandage work to do on the couch at home. And it's boring. Yeah. So that's even probably my biggest sales tactic.
Yeah. Even I give an example here. For example, even at the early stage when they're very irritable, where they can't even do cycling and rowing or anything else, I'll get them on the skier machine where you do with the cardio there, with a split stand. Really go put your heart out, get your sweat out, put your high intensity training, because these patients are really into fitness. They like to feel the sweat. They like to feel the high intensity stuff. So 2 points which I want to add here, which might be relevant here, is one is explain them what you're trying to do with the rehab. People want to know. People are always ask me, what is this exercise doing? How is it helping me? So I try to create a bit of a story and say, this is helping this muscle, this will help you for that. That's number one. Number two, give them a bit of goals to achieve. So I'll say to them, I want you to sort of, very simple, single leg hip abduction with 1 kilos. I want you to do 12 of those. So that's your homework. So they have a homework to achieve. They'll say, you should be able to do a single leg press 80% of your body weight. I'm just giving you some benchmark which you can modify here. So you need to give them something to work towards, to some sort of goalpost. Otherwise, there's nothing really tangible here, So explain to them why you're doing this, keep it fun, and also give them something to aim for, because these patients are goal-driven patients. They are into events like high rocks. They're into running. They like that competitive environment. They like that having the challenge here. Would you agree?
Absolutely. Because I've got to put myself, being a competitive, sporty person, this is how I would want to be treated as well. And this is honestly what you're saying is exactly what we've done with this female masters hockey player. Again, it's a conservative case. I know it's not directly, we're talking about pre-surgery here, but I still think the concept works because her pain, thankfully, is settled. It's still a little bit irritable, but she is in the gym and she's pushing herself hard, sending me videos, which I will put onto a reel and share on Instagram at some point, but she's blitzing her weights because all we've done is changed how she's doing things a little bit. We've managed her day-to-day load with her sport, etc. And she's actually enjoying being in the gym again.
And that's a happy place for her, isn't it? It's a happy place for
self-efficacy. Self-efficacy. We mentioned it in the last episode. We need to build self-efficacy because that really helps outcomes. So that's my biggest one of. Motivate your clients.
And talking about self-efficacy, that goes nicely with the last point here, is psychological and cognitive factors. This is an area where, I've been honest, I didn't really give much importance because I used to think these are young, active people. They are very strong mentally, but you can't be, it's not always the case. A lot of these patients have fear avoidance behavior, catastrophizations. They might have coexisting mental health conditions like anxiety, depressions. So a big one is fear avoidance. They're worried about getting arthritis. They're worried about they'll never able to be at that level again. They're worried that they can't play with the kids. So one of the key things I asked them on day one is, what's the biggest concern you have? What do you think, what do you worry about the most, And what do you think if rehab doesn't, how is it affecting your day-to-day life? How is it affecting family? So I look at the person behind the face syndrome. What are their emotions? What are the fears? What are the concerns? What do you think they're expecting? So the psychological screening obviously can do by chatting, but we can also use outcome measures like, you mentioned like the IHOT, the 3, or we can use a bit more specific. But it's really important not to miss the psychological dimension here, because although they're young and fit, no one is immune to mental health issues. And also the biggest issues they have is the fear of not being good enough off with the hip. They feel they're going to let down the team members. They're never going to be good enough, or they can't be good enough for the kids. So that is the biggest worry, I feel. How do you pick these cases in your cases, Callum? How do you suss them out without being like a psychologist,
No, absolutely. We're not psychologists, but we do follow a biopsychosocial lens, don't we? And this is where I think some of the best physios are just fantastic at talking and communicating, looking at the human behind the hip. I've had recently, I don't know why, I don't know if it's my English accent, Benoy, I'm not sure what it is, but in Perth, I've had quite a few tears in probably the last in the initial consultation. And first time I've met these people. And sometimes it is just a simple, how are you? How are you doing? How are things? Is there anything that you want to share with me? And sometimes just having a soft voice, soft approach, it can hopefully help your patient feel listened to and help them feel heard. I keep referencing this elite masters hockey player. After our initial consultation, I spent an hour with her because I had the time. She just said to me, thank you for understanding why this is important to me. Now, for her to say that, I can only assume that previously maybe she didn't feel heard. I'm not sure. It's not me bad-mouthing the prior physios, but we need to make sure that our patients are feeling heard and are feeling listened to. We don't have to come up with a solution to help them not feel depressed or to not feel low. I think sometimes it can just be helpful to help a patient feel that you're listening, that they're heard, and that you are there for them by their side. Don't try and cure depression, anxiety. We can't do that. Just make sure they're listened to, make sure they're heard. Don't interrupt them. What's that study, Benoy? Do we interrupt every 11 seconds or something?
Especially in private care.
GP study.
But still, I think we're still guilty. And,
100%.
And also the thing would be is, don't forget the person behind it, because they also have the same fears and issues with that. And there's nothing wrong in asking them. You might have the best technical knowledge. You can read the best journal and articles, but if you can't connect to the person, you lost them. You can give them can have the best rehab program in the world and the hands-on treatment, or you can refer them for injection. It doesn't really matter if they don't see that you made them valuable as a person, they feel don't connected. I can't emphasize this enough. And sometimes, I mean, I would say there's some advantage being an expert because they naturally feel a bit more calmer. This is what I think when you're a junior, you can struggle. But again, it's a skill where I struggle with initially, and we can get better with that. And generally, physios, we have the human skill. And what would you say somebody who's sort of new, how can they improve that element there? What do you say to other, especially like a junior physio?
On the communication?
Yeah. And getting the rapport and the emotional connection. Yeah.
Yeah. Again, there isn't a script. It would just, look, when they first come into that consultation, just say, hello, my name is. Ask them, how's your weekend been? How have you been recently? Where have you come in from? Where have you traveled from? You know, just have a general conversation. You know, sometimes I say to people, have you ever been to this clinic before? And they say, no, I've never been. And I go, oh, well, that's a good sign because it must mean you're pretty healthy then. And then they have a bit of a laugh because we don't want to have you in clinic. So if you're new to here, that's amazing. So just find a way to, you'd have to be the funniest person, but just find a way to build a human connection with them just by having a general conversation. That's it.
Yes.
Then when you sit down, this is something that I say to all juniors. In your subjective assessment, let them do the talking. I can't remember, William Osler, that's who it is. William Osler, MD from 18 something, would say, listen to your patient, because if you listen carefully enough, they're telling you what's wrong. And I don't just mean the hip diagnosis. They will divulge everything that's going on with them. And then we can note everything down. So if I'm going to say anything to a junior, it would be just talk to them as human, don't interrupt them, listen to them, let them share their story, and then repeat their story back to them, repeat back their concerns. So just so I understand, is this where your head is? Is this what you're thinking? Is this where your goals are? And if you repeat it back to them and they say, yeah, that's exactly it, then they feel that they're listened to. Yeah. They would be my top tips.
And one more thing I will add is I do have a list of, because I see some quite complicated cases. So I had 2-3 patients who, similar like you, they were crying and they were quite distressed. If you find they're distressed and is affecting their relationship, so I have a list of online registered psychologists who deal with injury. So try to refer them on. You know, I suggest to them, I'll help you with rehab, but I think you will benefit. And most patients take that because they know that. So this was, give an example. This was a patient who had 2 failed hip scopes, you know, and she was getting married very soon. So it's a very difficult condition. 3rd surgery. She's still on crutches, work issues. So, you know, there's a lot going on in her life here. And the emotional impact was huge. And she was working in a very high pressure environment as well. So I said to her, have you considered getting some help? And this is where working with a psychologist who has experience with the sports sides of psychology, who deals with injury rehab, the fear avoidance, they can be extremely useful. So again, add that to your network. And all of these things can be done online. Yeah, this can be done online. You don't have to go to the clinic. So they may not take it, but at least you can say, if you do need that, I can help you with this sort of patients as well. So we're going to help them out. So not for everyone. You might get one in every few months where you feel it's beyond your scope, and they might benefit from a more psychosocial input from an appropriate trained professional, which is our job is to identify it and then to refer them on. Excellent. So those are my sort of checklist here. So what would you say from those key points for those our listeners?
Yep. So if you're just tuning into the end, which I really hope you haven't, and you've listened to us for the full half hour. So your checklist that you're going through is to make sure the diagnosis is correct. Are you actually dealing with FAI, or is it the mimickers? We have an episode that's covered all the the key mimickers, if you like, to go back and listen to. Has there been a failure to modify the day-to-day activities, work, walking, etc.? Have the exercises been too much too soon? Have they been inappropriate for the timeline of that person's rehab? So failure to modify activity or modify exercises. Is the morphology too severe? Benoy, you mentioned alpha angle. Again, we've done a whole imaging episode to go back and listen to, but the alpha angle is when we're talking about the size of someone's cam. Is it just too big? And is it then a discussion of surgery or not? Generic rehabilitation. Make sure your athletic person in particular feels stimulated with their rehab. Make sure it's appropriate for them, not too passive. It's got to help them feel engaged. Set milestones, set targets, set goals that they can adhere to and be consistent with. And it's respecting psychological factors, self-efficacy. whether it's low self-efficacy, are they catastrophizing? Is it fear avoidance behavior? Do we need to lean on other members of the MDT, like psychology referrals, where needed? That would be a summary, Benoy, would you say, of everything?
Yeah, and definitely last point is don't feel bad. Like I would say, like you can't help everyone, and some people need surgery. Some people, we talked in the previous episode, some people need injections. It's too irritable. So you do the best you can, and they'll thank you. Even if, as I told you before, even if you fail your rehab, it's not failure, it's prehab for the patient. That all the work you've done for that 3-4 months, they're going to be stronger and fitter before the surgery. So, and I would say my patient caseload, my surgical referral is something like 40-50%, because they've done everything. There's nothing more. I'm just like a last tick box exercise. So I can't take it personally that I'm not helping everyone, because it depends on the chain you are. If you're like an expert or a specialist, by the time they see you, it's too down for the line, isn't it? So you can't really help them out, and it's not a reflection. And sometimes people come to you, and that can be a problem, like what I call a specialist trap. They come to you and say they want you to fix them and avoid surgery. And I say to them, sorry, I don't think any amount of physio, I can do physio for another 6 months or 1 year, but I don't think this will make a big difference on that. So, and having the courage to stand up and that can take a bit of time. I found it very hard initially to be very, do you find that where you have to be quite bold and very clear, not being nasty or unempathetic, but you just, sometimes people don't want to listen that. They don't want, they just want to go on. I don't want surgery. And sometimes you have to be very honest and say, you must get an opinion. How do you deal with that when patients don't want to hear that next phase,
Yeah, it hurts the ego a bit, doesn't it? We have to be honest.
Yeah.
It does hurt our pride. We've all got a bit of ego, and it does hurt. But look, that's where you'll call yourself a specialist physio, if you like, or a consultant physio. It's not because you have then are going to do anything drastically different to what another physio does. It's, can you recognize when an injection is appropriate and it's not a dirty word? Can you recognize when surgery or orthopedic referral for possibility of surgery is needed? Sometimes you need to be the person to stand there and say that, and that is okay to do. It doesn't mean you failed. Doesn't mean you failed them. It's hard because you feel, I haven't been able to do anything to help you here. But if you think you're not directly with your hands helping them, but if you can spot where the referral next needs to go, you are actually indirectly helping them, because you're having the conversation that maybe others before you didn't feel they could have. So they're difficult. There isn't a script. It's just going through this kind of, I suppose, framework, Benoy, that you've set out. And if things are being sort of ticked off and everything looks okay, that's your due diligence. You've done your bit.
Yeah.
And then refer on.
Yeah. And I think 2 things which help me is whenever I have those difficult conversations, I go back to 2 questions. First thing is, am I being honest with my patient here? Am I telling them the whole spectrum here? Honesty is the most important thing. Second thing is, what would I say if this was a family member? If it was my sister or my parent, what would I say to them? Would I just sugarcoat them? So just treat them with the same empathy as you would as a family member. I'm being honest. And sometimes it's not what they want. They may not see it straight away, but they'll thank you later and say, he's been very honest on that. But that's all. We can't really impress everyone, but we have to be honest and empathetic. That's something which we can definitely help our people to go. So I think that wraps up nicely. So anything planned on during spring or summer, or obviously the season is a bit different? Anything coming up from you, visitors coming from the UK, or anything planned, Callum, for the rest of the year?
Have got the Easter weekend. We've got the Easter weekend coming up. So we're going to take a trip down south of South WA. Anyone wants to look where that is on the map? It looks beautiful down that way. We've got my parents visiting in a couple of weeks.
Yeah.
I'll be back in the UK next year, Benoy. I know you're missing me.
Yeah. Do you know which time of the year would it be? Which time? When you think? Which early part or late part? What do you think?
No, it'll probably be the tail end. It'll probably be the later part of the year.
Yeah.
Yeah. Speaking of which, because you said this in the last episode, Benoy, I'm going to just repeat it again. Because you and I have had messages on LinkedIn and Instagram, people asking, Callum, do you do an online course? And I'm directing them your way, to be fair, Benoy, because you're in Europe. I'm quite far from Europe at the moment. But two requests I have for our listeners, viewers. One, throw shade at Benoy, because he has not invited me to Holland to help him teach. Throw shade at him. And the second part is, if people would like a joint course, because you said it's on record, Benoy, let's meet in Thailand or Bali. You said it in the last episode. If people would like myself and Benoy to run a joint course, just
we've done
send
it before
us some
anyway.
messages.
We definitely. You see, we've done definitely. We're definitely aiming one when you're back in when you're in London. That's definitely happening.
Absolutely,
we'll do on that. But again, we can do like a bit of a pub meet or like a meet and greet straight from the Hip podcast in the evening. We can sort of, because I got space. We get space from the clinic. You know, more like a chat. I think it'll be good to because I don't think we don't know enough of this sort of social meets, especially, isn't it? We don't need to have an agenda. So I'm sure we can plan something, isn't it? So 100%. We can,
Have you got your Easter egg? Have you got your Easter eggs for your family, Benoy?
Yeah. So I'm getting some. We're going to Birmingham this on Easter break, so I'm looking forward to it. So yeah, we need that bit of time to recharge and back with the family. So thank you guys. So thanking us for joining us, and we look forward to the next. And also, an exciting thing, I've also recorded recently a bonus special episode with a leading hip surgeon, Karthik, on hip resurfacing, which will come on the podcast channel as well. So we'll be adding some guest special events, me and Callum, because we go and meet many surgeons, and it's quite difficult to have all in the same room. So we record it on the fly, and then we'll be putting on that, because we need to also know what are the leading guys doing, people doing in this field, both for conservative as well as surgical. So some exciting specialist episodes coming in. So watch out for that on our channel. Thank you, guys.
Cheers, guys.